Health Sciences here at the Boston University School of Public Health. Monica has multiple other positions. She is also an adjunct associate professor at the Harvard Chan School of Public Health. She is also our executive editor of Public Health Post. Monica has been really committed to understanding the science of communications in the larger public health field and to looking at the real world application of some of these strategies in understanding the challenges and confronting them. Monica, thank you for moderating today for us and for bringing together an amazing panel. I will switch off right now, but I'll be listening to this conversation. Over to you. Thank you very much.
Thank you, Dean Hyder, for that introduction. And thank you again to everyone for joining us. I now have the privilege of introducing our speakers. First, we'll hear from Tracy Hong. Professor Hong is a professor of media science at the Boston University College of Communication. She teaches courses on persuasion theory, media effects, and communication research methods. Her program of research is at the nexus of health communication and new media technologies, where she advances communication theory by leveraging media, including new media and social media, to promote behavioral change that can lead to beneficial health outcomes. Her work topics span smoking, vaping, alcohol use, peer influence in virtual environments, and vaccine hesitancy. Our next panelist is Jeff Niederdeppe. Professor Niederdeppe is the Liberty Hyde Bailey Professor of Communication in the College of Agriculture and Life Sciences and Senior Associate Dean of Faculty and Research in the Jeb E. Brooks School of Policy at Cornell University. He is also founding co-director of the Collaborative on Media and Messaging for Health and Social Policy, and associate director of the Cornell Health Policy Center. His research examines the content and effects of mass media campaigns, strategic messages, news and social media in shaping health and social policy. Our final panelist is Dr. Sherry Pagoto. Dr. Pagoto is a licensed clinical psychologist, professor, and behavioral scientist. She's a professor in the Department of Allied Health Sciences at the University of Connecticut, director of the UConn Center for mHealth and Social Media, and past president of the Society of Behavioral Medicine. Her research focuses on leveraging technology, social media for health promotion, and as an early social media pioneer in academia, she has traveled to universities and conferences nationally and globally to give trainings in how to develop a social media presence. As a reminder for our audience, following each individual presentation, we'll turn to a moderated group discussion. When we have about 20 minutes left in the program, I'll also look to the audience questions, so feel free to submit questions through the chat. As a reminder, the Zoom's Q&A function is located in the bottom middle of your screen. Professor Hong, I will turn it over to you.
Thank you, Monica, and thank you, Dean Hyder. Delighted to be with you today and very excited to be on this panel with my esteemed fellow researchers, Jeff and Sherry. I'll try to share my screen here. All right, so much of my work, as Monica described, uses AI and machine learning to analyze how people talk about health on social media and how they process social media messages from vaccines to tobacco to public trust. But behind the algorithm, my focus is really on human behavior, what persuades us, what builds trust, and to a greater extent, why timing matters. For me, it's fascinating that while our tools have evolved, the principles of persuasion, first described by Aristotle over 2,000 years ago, still shape how we connect and influence today. So for the next 10 minutes, I'm going to translate those ancient principles of persuasion into the language of algorithms. Now, Aristotle was the first to systematically study and define persuasion. And just for fun, I generated him in AI generated version of Aristotle on the right, staring at his version, his old version, the marble bust version, as an ancient artifact here. So looking towards the future here, but also looking back over 2,000 years ago when persuasion really began. But before we get to algorithms, now let's pause on how the human mind itself processes persuasion, how persuasion unfolds in today's social media landscape of constant motion, distraction, speeds, and swiping. Here you see a recent poll from Gallup, which shows that our kids spend close to 5 hours a day basically swiping through social media, scrolling, liking, reacting. When you think about it, 5 hours a day, that's almost a full work week where kids are just immersed in social media. And so when I think about how the media landscape has trained us to think differently now, you can go back to the cognitive psychologist Daniel Kahneman, who called this fast thinking. It's emotional, it's automatic, it's intuitive judgment. It's very efficient in everyday life, particularly with social media, but it doesn't leave much room and space for reflection, for deliberation, for what we call deep thinking. And that's what social media does. It facilitates and trains our mind to think fast. And we've lost the art of slow thinking, which is the other decision-making way of thinking about information that Kahneman talked about. This slow thinking requires effort. It's analytical, it's reason, it's deliberative. It's the kind of thinking that underlies real attitude change. 30-second short form videos on TikTok doesn't really give you room for short thinking, but it does give you a lot of dopamine hits. And this distinction connects directly to one of our foundational persuasion models, ELM. There's a lot of other dual process models like ELM. HSM is one that comes to mind, but the idea is very similar here, which is the central route is the route of deep, deliberate thinking. The peripheral route relies on shortcuts, heuristic cues to help us make decisions with regard to persuasive messages. And the digital distractions, though, that we see every day inhibits the ability to elaborate, to engage deeply. So we're always in the peripheral route of persuasion, and we're not really thinking deeply about what's going on. The challenge in today's digital environment is that constant notification, scrolling, and multitasking reduces our ability to engage deeply. In other words, the design of the media, of social media, keeps us in a fast thinking mode, and that means more peripheral processing and less critical reflection. In a lot of ways, that's why misinformation proliferates. It's a lot of ways why we don't judge things that should be wrong, instead we accept them without thinking deeply. So when we talk about public health communication or even trust in science, we're not just competing for attention, we're really competing for cognitive depth in an ecosystem that's optimized for distraction. Let's take an example of problem of thinking fast on social media. And this comes to our first Aristotle modes of persuasion, which is ethos. Ethos is essentially the credibility or believability of source. And so here's the first example I have, which is Dr. Sanjay Gupta, very well-known TV personality, a neurosurgeon, I believe he is, that's on CNN. And so in the digital translation of ethos, of Aristotle's ethos, is that we should use health influencers and authentic health experts on social media like Dr. Sanjay Gupta. The problem is that in the last 5 years, we see a lot of cheap fakes and deep fakes that make credibility harder to detect. And the fast thinking does not allow for deep deliberation for us to really think, is this video of Sanjay real or not? So I'm going to show you of a video of Sanjay that's not real.
I want to say that this is truly a landmark in modern medicine, and I am honored to be a part of it. Today, new hope is born. In fact, I'd call it a new certainty.
I would probably call that more of a cheap fake because it's not an entirely AI generated image of Sanjay Gupta. But this one is the next slide. This next slide here of a pretty famous influencer, Dr. Joel Borvell, is definitely a deep fake. And here is a screenshot image of him talking about his deep fake video. So this is not the picture of him in the scrubs. That's not Dr. Borvell. That's a deep fake image of him. But this is a really good example of why thinking slow, we need thinking slow to detect credible sources. But the media, the social media has trained us and our kids in particular to not think slow, but to think fast. So that leads us to the next question, which is how do we encourage thinking slow? And I think there are a lot of ways that we can do that. And we can do that in a way where we're using the tools, the AI tools, the data tools to actually encourage thinking slow. And I'm going to give you some examples from my research of this. The first is, how do we get logos? How do we get people to think about reason, to think about the argument? And one way we can do that is to use dashboards, data visualization, data storytelling, and let the audience engage with the data, make it transparent, be a part of that process. This is a screenshot of a research I conducted last year with a group of research from Indonesia. And what we did is we developed a classifier to detect hate speech in Indonesia. And in particular, in this hate speech, we also put, during the Indonesian election, which was very contentious. But what we also did is we put a dashboard here where people can see and engage with that data and with that research and visualize and see how hate speech has proliferated and changed throughout the election process. So using data storytelling and dashboards can facilitate slow thinking, which is what we want our audience to be. Another tool that we can also use is warning labels. And warning labels can reduce engagement and slow the algorithm visibility. This is a study we did in 2024 in JAMA Network Open. And what we find is that health warning labels can reduce engagement. And I know that sounds counterintuitive because usually when people are on social media, they want engagement. But we don't necessarily want engagement for products that are detrimental to one's health. The example we used here is synthetic vaping products, which at that time were not very much regulated by the FDA because it circumvented some of the rulings there. But here what we see is that if they engage less with a problematic content such as these, it leads to reduced visibility in the algorithm. So it doesn't come on top in your algorithm feed. And that helps slow down some of these contentious content. And it slows another persuasion principle, which is called social proof. Social proof is the idea that if everyone is viewing, liking a post or video, they are more inclined to do so as well because everyone else is doing it. And so what we did here is we use these AI tools to develop a warning label multi-layer classifier, which we call Wally, to classify hundreds of thousands of social media images to see if they have health warnings and if those health warnings are FDA compliant. And what we find that it reduces engagements. Warning labels receive fewer comments, and the larger the warning label, the fewer the comments. Warning labels also promote more logic and deep thinking than just relying on pathos, which Aristotle called the emotional side of persuasion. So a lot of tobacco products are lifestyle oriented. They rely heavily on pathos to evoke emotions and not logic. And when you put warning labels in these products, it promotes logic and it gets people to pause and think more deeply than instead of being emotionally driven to use a product. And then this gets us to the last, perhaps not as well discussed concept of persuasion for Aristotle, which is kairos. And kairos is the idea that the ability, Aristotle defined kairos as the ability to deliver the right message to the right audience at the right time. And what I see here is our kairos opportunity, a moment when public attention and digital innovation can converge. By applying AI tools strategically, we can make persuasion in the digital age impactful. We have a very interesting time right now where there is declining trust in science, which you see on the left side, but at the same time, people are talking more about science news than ever before. They're reading more science news, they're talking more about science. So this is a really interesting moment where we can use the very persuasive leverage tools in persuasion in digital age. And what do I mean by that? I'm going to give you two examples. One example here is a data that we scrape from Twitter, and we use social network analysis to identify influencers. And from those influencers, we can identify who drives the conversations, who drives the conversation's visibility and diffusion. We could detect gatekeeper, which is a very old persuasion concept. Those are the people who bridge communities and control the flow of information across clusters. We can also detect the opinion leaders. Those are the ones who are who control the ethos in the network age. Those are the ones that people go to when they want to hear about politics or about health. And of course, the ones that are most essential that we could visualize are those that are in the green, those accounts, those individual accounts, which operate both as an opinion leader and as a gatekeeper. So we can use the tools that create the slow thinking, essentially, and we can use those tools to help us promote persuasion in health in this digital age. And I want to show this last slide here. And the idea is like, though social network, we can visualize persuasion as a structure, not just as a message. And social media lets us use kairos of communication, the moment when connection is possible. In this study here, where Twitter was banned by the Nigerian government, what it shows us, it shows us what happens when the kairos disappears, when timing of communication breaks, misinformation fills the vacuum. So in this particular case, we looked at vaccine misinformation, and during the Twitter ban of Nigeria, vaccine misinformation increased, and you see that in time too. It wasn't a huge increase, it was a significant increase, a small increase, and we compared that against Ghana, which acted as our counterfactual control. What we find is that using multi-layered data sets across different languages, across global landscape, we can develop tools that can help us identify when there is a problem moment. And when there is a problem moment, we can use that hierarchical moment to harness AI tools to build trust. What our data shows here, from Twitter ban to broader government restrictions, it's that silence leaves space for misinformation, but the same tools that can distort truth can also amplify it. This is a chaotic moment to use AI and networks to promote science and to re-engage the public. I'm happy to share any of these research through my, please email me at tjhong@bu.edu, or any of the institutes that I'm affiliated with, BUCOM, the Center for Emerging Infectious Disease, as well as Hariri.
Many thanks, Professor Hong. Up next, we will hear from Professor Niederdeppy.
Wonderful. Thanks, Monica, and thanks, Dean Hyder, for the invitation to be here today. I'm going to share my screen now. All right, so I'm going to spend my 10 minutes reflecting a bit on communicating about public health and health policy, not just health behavior, in the context of a complex, dynamic, networked media environment, and within what I think we could all agree is a challenging political climate. Let's see, there we go. Why is it not advancing? There we go. I'm going to sort of start with a preview of the key takeaways today. First, I'm going to make the case that when we communicate about public health and policy, we do so more effectively when we combine scholarly knowledge with practice-based wisdom. This goes along with the point that Dean Hyder made earlier about persuasion being both an art and a science. Second, through research that incorporates scholarly and practice knowledge, I'm going to provide evidence that in this moment, in intense political disagreement, that messaging about racial inequality in particular is not inherently divisive, even in this moment when it has been suggested it is such. And then I'm going to spend a little bit of time talking about how the centrality of our media environment of social media platforms, particularly among young people, changes some things that we know and that we need to approach persuasion and persuasion research, but it doesn't change everything. I'm going to try to key in on some of the things that it does and does not change. So I'll start with this point that we communicate more effectively when we combine scholarly evidence and knowledge with practice-based wisdom. What I'm showing you here is a basically summary of meta-analyses of persuasion tactics that have been studied in the scholarly literature for a long time. And I'm not going to get into the specifics here, except to point out that a couple of things stand out to me here as being particularly effective and predictably effective. And that is evidence and argument, that people respond well to evidence and strong arguments. And I want to hold that and come back to it in a moment. We've learned this from decades of scholarly work. What that doesn't tell us is how to incorporate that evidence and argument into particular messaging contexts that we care about in health and health policy. And so we have done work over the last couple of years to understand what kinds of practice-based recommendations are being made to public health advocacy organizations and actors in the context of health policy and social equity. And you can see that they emphasize some somewhat different things. If you're going to talk about health and social policy, we need to emphasize structural causes and solutions for problems, not just behavioral. We need to lead with shared values that bring communities together, that we need to frame these issues in terms of their universal impact, that this affects all of us, for instance. And we need to include a call to action. We need to tell people what they need to do to advance these kinds of social policies. And so, armed with this, both practice-based knowledge and scholarly evidence, we developed a series of studies that were designed to test whether these integrations can help us move the needle on pressing health policy topics of our time. So we incorporated insights from practice-based research on health policy messaging, which included, naming the problem but leading with values, identifying structural causes of the problem and ending with a call to action, but also building in insights from our own work and from the scholarly literature, which highlighted the importance of providing evidence that these policies work. And I'll talk about specific policies in a moment. And also bringing into question this idea of the need to frame issues in terms of their benefits to all groups, or whether you can talk about that and also center the impact of health policies that disproportionately benefit those communities of color who have highest rates of poverty and suffer health inequities in many different contexts. Through this work, we have concluded that communicating about racial inequality is, in fact, not inherently divisive and can bring various actors and identities together in support of evidence-based health policies. To illustrate this first, I'll talk about data from a study that we conducted surrounding child tax credit expansion. Child tax credit is a policy that provides money to families with young children to help support those children. And this was expanded for a brief period in 2021 and had massive impacts on reducing levels of childhood poverty, reducing food insecurity, reducing housing insecurity, increasing mental health and other health-related outcomes. Just an incredible policy that was in place for a short period of time and then expired. So we developed messages focused on expanding child tax credit. And we did that in two ways. One, in a message that emphasized its universal impact on all children in poverty, and that's the universalist appeal. And a second message which emphasized both its universal impact, but also its disproportionately large impact on reducing rates of childhood poverty among Black, Hispanic, and Indigenous children. And what we see from our results is that exposure to either the universalist or targeted universalist message increased support for child tax credit expansion among Black and Hispanic respondents, and also among white respondents, although by a smaller margin for the targeted universalist message. Interestingly, it also increased intentions to advocate for these policies by, say, contacting an elected official among Black and Hispanic respondents, but had no such effects among white respondents. But again, the targeted universalist message did essentially no different than the universalist appeal. It didn't undermine impact on outgroup populations, in this case, white respondents for whom those targeted benefits were not as large. We then analyzed these message effects by political ideology and found a very similar pattern. Both Democrats and Republicans increased their level of support for child tax credit expansion in response to both the universalist and targeted universalist appeal. Democrats were also motivated to advocate for these policies in response to both message strategies. We then replicated these findings in the context of opioid treatment policy, that is, states requiring FDA-required medication for opioid treatment. And here we see very similar patterns across the board for both Black respondents and white respondents in terms of both moving support for the policy and increasing their intentions to advocate. We saw a parallel pattern of sort of equivalent impact of these messages among Democrats and Republicans. The one place where we saw a little bit of difference is in the context of protecting Medicaid. We conducted this study right when there were lots of discussions about whether or not to cut Medicaid in the sort of bill that was being discussed in June. And we see in that context somewhat less movement across the board, although not obvious differences in the impact of those messages between the targeted and the universalist appeal. So from this work, we conclude a few things. One, that messaging about racial inequality is not inherently divisive. We saw a similar pattern of effects across racial and ethnic groups and political identities. That centering perspectives from historically excluded populations, that is, populations who aren't often represented in our message testing studies in health policy and health behavior, yields novel insights. We saw greater impact in a couple of contexts on intentions to advocate for these policies. And that messaging that combines both practice-based recommendations and scholarly evidence can help shift the needle on challenging health policy topics in a time of political division. The last thing I'll spend just a couple of moments on is reflections on what changes and what doesn't change in the context of a media ecosystem that has a central role for social media. I think we can say quite a few things are different. Social media platforms, for instance, favor video over text. As Tracy suggested, they make it difficult to identify original sources and make it easier to fabricate sources. They privilege very short messages, slow thinking versus more nuance and complexity. They rely on message retransmission, sharing and commenting and elevating messages. And once they're in a networked environment, a messenger from a public health authority loses some control of that message as it sort of evolves in the media ecosystem. And social media is inherently relational. That is to say, messages come with them, the person who shared them and the person who comments on them and the networks in which we are all embedded in our social media platforms, which encourage confirmation bias. I'm going to skip some methodological challenges that come from this, but what I want to end with is to say, despite those differences, there are a lot of things that we have learned and that we've known from decades of persuasion and health communication research that's still the same. Public health communicators have always needed to meet audiences where they are on the media or platforms they use, whether that is TikTok or local TV news. And for some populations, young people, that's likely TikTok and Instagram and WhatsApp. But for others, it may not be. In fact, we know that elderly populations are using different kinds of media. It's always been important to meet audiences where they are. But we always have to compete in public health communication with well-funded oppositional forces, whether they're selling products or representing powerful interests. And they're often able to outspend public health, and we have to figure out how we're going to compete with that messaging. We've always needed to identify credible sources to communicate about public health. And while public health itself may occupy a less credible authority in this moment in time, the need to identify those credible sources has always been part of effective messaging. And we need to create opportunities for exchange and feedback on messaging. We can't just put our messages out there and hope they land. We need mechanisms of feedback on both the messages and the topics on which they communicate. We need bidirectional communication. And in many ways, social media makes that easier due to the network nature of our systems. So I'm going to close there. Feel free to read more about my and my team's research from comhsp.org. And if you take a screenshot and click on that URL, I'm sorry, code, you'll take you to an opportunity to subscribe to our newsletter. Thank you very much.
Thank you, Professor Nidra Depi. Finally, we will turn to Dr. Sherry Pagodo.
Thank you. All right, I'm gonna get my screen share going. All right, here we are. All right, so I am going to be talking about why we fall for misinformation and what to do about it. So, like Dr. Wang said in my introduction, I'm a clinical psychologist and I do a lot of trainings for academics and public health professionals on social media. I have for many years, back when Twitter was Twitter and shiny and new and exciting. And a lot of the advice that I've given has actually evolved. And so I kind of wanted to talk a little bit about my current thinking around misinformation and bias. And so let's dive in. All right. So the first thing I wanted to kind of start level setting with is this statement here is that everybody thinks other people fall for misinformation, but nobody thinks that they fall for misinformation. And I think this is something that we all have to kind of do some introspection on, and that we're all very vulnerable to misinformation. Even if you're a public health professional, no matter who you are and how much education you have, we're all vulnerable to misinformation. It plays on our cognitive biases. And there's actually some data to support this. There's a study that came out in 2019 that surveyed both Democrats and Republicans. And it's interesting, they each think each other is more vulnerable to misinformation. And they each think of themselves as less vulnerable to misinformation. So are they right? Is one side right or more right than the other? Actually, neither side is necessarily correct. There was a systematic or meta-analysis that was done a few years ago, this 2019, where they looked at partisan bias in liberals and conservatives. And what they found, here's a quote from the discussion that I feel like really kind of captures the finding, is that the clearest finding was the robustness of partisan bias, and it was actually on both sides. There was a tendency for participants to find otherwise identical information more valid and compelling when it confirmed rather than challenged their political affinities. And that was across all kinds of samples and different ways of measuring political orientation. So I think that we need to kind of begin from a point of humility in that we are subject to cognitive biases, just like everybody else. And so I wanted to put out this thought question, something to think about today and going forward is, are we as public health professionals as motivated to change our own bias thinking as we are to change other people's? Because we do talk a lot about how do we change other people's biases, but are we thinking about our own biases and how that may be playing into how we communicate in the work that we do? So, so something to kind of think about. So let's talk about cognitive biases. And cognitive biases, like I said, are universal. We're all vulnerable to these things. Confirmation bias is a tendency to believe information that's consistent with your held beliefs. So back like what Tracy was saying, this is kind of part of that fast thinking is we see something that's really consistent with our beliefs. We're like, yep, I'm going to hit the like button on that. That's got to be true. Bandwagon effect is where a lot of people on your side may be saying the same thing, and so you assume it's true. And that's kind of related to the illusory bias, which is where a message that's heard repeatedly from different sources is believed to be true. Now, the next one is one that really social media platforms take advantage of, which is the negativity bias. This is where any emotionally charged content is going to get our attention more so. So we're more likely to view it or more likely to engage in it because it's going to move us to action. So whether that's, fear appeals or, something that makes you angry, it's just going to get more attention from us. And then that's also going to give it more attention from the algorithm. And then, of course, partisan bias. That's when we are more likely to believe things that align with our political beliefs. Okay, so let's talk about the social media algorithm because it's really amplifying this sort of human condition of cognitive biases. So the social media platforms are doing less content moderation than they were a few years ago. And so that results in, we're seeing more misinformation. It's harder to measure because as researchers, we don't even have good access to social media platform data so much anymore. And that results in strengthened biases. So the more misinformation that's out there, the more our biases may become strengthened. So social media is becoming a really difficult place to navigate for everybody. And here's the thing. So if we engage in content, it's definitely going to feed the algorithm to show us more of that content and to elevate that content for other people to see. But it's not even just engaging, it's viewing that content. Even you spend a little bit of time looking at it, and that's also going to feed the algorithm. And the third thing I wanted to mention is content homogenization. So you may have noticed that in your own social media feeds is that you're starting to see a lot of the same things. The minute you click on one thing, you're going to see a ton more of whatever that thing is. It could be a pair of jeans, it could be a political post, it could be anything. And you're just going to get fire hosed with that. And so the heterogeneity of the content that we're seeing is actually becoming more and more narrow. And so we want to be very mindful of what we're spending our time on social media. Okay, so with all of this going on, what is a public health professional to do? We have this environment that's full of misinformation. It's like a fire hose. It's going at the people, the communities that we want to try to help. So what can we do about this? And it's affecting us as well. So I have a couple of ideas here. One is to learn more about what people who think differently than you value. So this is a focus on values. We tend to want to focus on facts and debunking facts and that sort of thing. But I think there's something to be said for backing up and thinking about what are the values of the populations, whose minds we want to change. So a case in point, the MAHA folks, Make America Healthy Again, they value individual choice. They value personal responsibility. They are compelled by personal testimonies. They're skeptical of regulatory science. And for good reasons, there's a lot of communities that have not been respected by science, that feel that they've been ignored by science. They are skeptical of expert consensus and they're skeptical of mandates. We definitely learned that during the pandemic. So it may be better to spend our conversations learning about others' values rather than trying to necessarily change their minds when we're having discussions and that sort of thing. I wanted to do a plug for, I'm not involved in it, but I'm a huge super fan. The Why Do I Trust You podcast, maybe some of you have seen it. They're doing a fantastic job of bringing public health professionals together with MAHA grassroots organizers and having conversations where they talk about their values and they try to sort of bridge the gap. And there's been some cases of collaborations that have formed between these two groups. So I feel like these are the conversations that we need to start having. And so it's really exciting what they're doing. So if you get a chance, definitely check that out. Okay, so my second recommendation, and I wrote about this in a piece in Psychology Today a couple months ago, is to lead with empathy. One thing we're seeing a lot on both sides is this accusation that the other side lacks empathy. And the truth is actually most human beings have empathy. I mean, most of us are not sociopaths, okay? The thing is that just because we have the capacity for empathy does not mean that we're leveraging it all the time, right? And so there are things that get in the way of our empathy. So when we feel stress, when we're feeling under threat, that diminishes our capacity for empathy. And there's actually a neurobiology to that. So when that fight or flight is going on, the parts of our brain that are lighting up have to do with protecting ourselves. And the part of our brain that's responsible for that slow thinking and critical thinking and analysis is an ability for empathy is deactivated. So we want to think about that as when we're getting very stressed out and seeing all of these divisive comments and things like that, it's probably not bringing our most empathic self forward. So strategies for sort of maintaining and maximizing your empathy capacity would be to be mindful of the stress, of your stress, avoid unsolicited lectures and problem solving. People don't find that to be an expression of empathy, and it is often very unwanted, and asking questions. So curiosity really is the path to empathy, and which is what I love, again, about the podcast that I mentioned. So 3, science communication. I'm a big fan of science communication. How people can go about increasing their impact through science communication is certainly evolving. Right now, the social media platforms are like you're in a gigantic room and there's a whole bunch of people and they're all talking very loudly, and you want to be able to say something and be heard. So that's what it's like being on a social media platform right now. How do you get the signal through the noise? It's difficult. And so you have kind of 2 paths here. You can be a content creator, or you can be a content, what I call elevator. So a content creator, and there's a number of people who are doing a really fantastic job with this in the public health space. Now, these are people who are spending a lot of time creating content across platforms. It's multimedia. They've built giant audiences, and they're doing great work. Now, sometimes when you see folks like this, like the Dr. Jen Gunthers of the world, you wonder, like, that must be a lot of time. It must take a lot of time to engage in that level of science communication, and it does. And not everyone is going to be able to do that. In which case, the way to use your science or your social media presence is by elevating those voices. So figuring out like who are the big voices in public health on different topics, and how can I go about elevating them? So you don't have to become the next, Jen Gunther, but you can be part of the army that elevates the voices of people who are doing a great job like that. Because I think one thing that deters a lot of public health folks and academics is they're like, I don't know that I have time for all this social media, shooting videos, being on TikTok all the time. You don't have to, but you can elevate, and that could be part of your goal. I also wanted to kind of put out there the opportunity for alternative communication channels. Podcasts, for example. I really think of podcasts as like what social media was 15 years ago. This is where people are getting a lot of their information and listening to discussions. They're richer discussions, so it's not just a tweet or a post. They're actual dialogue. So to the extent that we can get into podcasts that open up audiences of different types. So you don't necessarily have to start your own podcast, but can you find ways to get on podcasts that have unique target audiences? I also love platforms that allow kind of tighter knit communities like Patreon, where maybe you don't have 10,000 followers, but you've got really engaged, smaller community type followers. Also, platforms like Substack, and then good old fashioned public facing news outlets, local news outlets. And I also want to kind of go back to basics, and we probably need to be doing a lot more grassroots community, boots on the ground events. We could be learning a lot from our CBPR, community-based participatory research colleagues, in terms of how do we get out there in communities and actually have real conversations rather than, 140 character social media posts. Maybe our impact is really in person in that way. Number 4, Public health, there's an AI for that. So I wanted to do like a little shout out to this article that I just came across. It's brand new. And it's talking about all the different ways that AI is being leveraged to create public health communication. So clever ways that folks are using DALL-E and Sora to create tailored messaging to all kinds of target populations. Take a look at what RTI is doing with generative AI, creating digital personas that can create message development that's tailored to different audiences, as well as NORC is doing some really interesting work with customizable chatbots that health departments can use that they can be trained on any kind of topic like vaccines, chronic disease prevention, you name it. And they're piloting this in different communities. So I really see this as kind of like an exciting future of public health communication. Okay, and so I wanted to kind of end on talking a little bit about the American Psychological Association's consensus statement around understanding and fighting health misinformation. This is a great piece of work where they really summarize the types of interventions that have been used and the evidence base for these interventions. And many of these you've probably heard of: debunking, media literacy interventions, pre-bunking, and nudging. One of the things is like there's a mixed literature in all of these things. There's not necessarily like kind of one sort of magic way that we're going to convince people that that something is misinformation. The ones that I think I'm most excited about are media literacy training and pre-bunking, particularly in K through 12. If we can really sort of prepare young people to be competent in this really vast and ever-evolving media environment, I think we can only do ourselves favors with that. So APA kind of had a number of recommendations, but these 4 I thought were kind of the ones I wanted to emphasize. So correcting misinformation with accurate information is certainly important. That said, it has to happen in concert with evidence-based strategies that promote healthy choices. So it's not enough to say, hey, no, that supplement does not work for hot flashes, or this doesn't, prevent disease, but then combining it with strategies that would be useful. Second, leveraging trusted sources to counter misinformation. We saw some great examples of this during the pandemic. And what this really does involve is figuring out who different population segments trust. And it may not necessarily be you, but how can you create partnerships with folks that they do find trustworthy? For number 3, pre-bunking misinformation to inoculate susceptible audiences. Like I said, I feel like there's a lot of interesting research along these lines, particularly if we're doing this in children as well as college students. And finally, funding basic and translational research into the psychology of health misinformation. One thing that you'll definitely see as a takeaway in the APA recommendations is that kind of the jury is still out as to what is most effective and particularly long-term effectiveness. So some of the interventions that have been done kind of work in the short term, but don't necessarily have those long-term effects. So we really do need more research in this space. So I also have a QR code here for our newsletter. So if you're interested in this topic, and our newsletter, which comes out every Friday morning into your inbox, talks about breaking news on these topics, job opportunities, as well as webinars, podcasts, as well as the latest research on all of these subjects and more. So that's what I have for you today, and looking forward to the discussion.
Thank you, Dr. Bogotto, and thank you to all of our panelists. We'll now move on to the moderated portion of the program. And I'm going to kick us off with a question or two, and then at around a little after 2, I'll turn it over to audience questions. And as a reminder, please submit your questions using the Zoom Q&A function. So my first question is, how can we effectively communicate when audiences seem to hold values or worldviews that it might feel increasingly difficult to find common ground? There might be complete opposite sides of the spectrum, and it is difficult to find a place where there might be some mutual understanding. So let me ask that first of Professor Hong, and then we'll turn it over to the other panelists.
Well, first of all, I really enjoyed Sherry's talk and Jeff's talk. And and thank you for these great questions, Monica. I think that there's a desire in the general public to want to engage when they're writing things like, you hear this a lot, common sense. It's common sense we shouldn't do this, or it's common sense we have too many vaccines on the MMR schedule. They for a very long time in academia, we would do the research and we would put in a research article and file it away. Now we have these tools that, for dashboards, or the example I have with the hate speech, the dashboards where you could see the data being collected live and people can interact with it. I think that is one way to break down the barriers and allows us to get into a conversation space that is safe, where you can interact with what the other people are doing, what they're finding, and to do it in a way that lets people begin that conversation. You're not going to convince somebody with very different values, but you have to listen to them and you have to do the work, the science work that you're doing, and to make it available, publicly available, let people interact with it, to see it, to question it, to engage with it. And I think that conversation begins people's ability and opens up people's ability to listen to each other and to begin to actually talk with each other, which is not something we do very well, quite particularly with health.
And I'd love to hear, Professor Niederdeppy, your reactions on this before we turn it over to Dr. Pagoto.
Yeah, I mean, I think both Tracy and Sherry alluded to this. You have to listen to people's concerns to know what values they're bringing to the table and what concerns they're bringing to the table. So again, I think effective communication is bidirectional. And when we have it in a conversation, we pick up on others' nonverbals and responses. And when we're broadcasting messages out into the ether, we're, I think, less likely to get that kind of information unless we're looking for it. So I think you have to look for it, number one. Number two, I think actually there's lots of values that are more broadly shared, and identifying ways that they're shared and ways that the public health sort of goal that you bring to the table is consistent with those values. So Sherry mentioned Maha valuing personal responsibility. I think everyone values personal responsibility in this country. It's often sort of the lead value on that comes up when it comes to food, when it comes to any kind of topic. But there's ways to work within that value. So yes, we all want our children to eat healthy diets, but you can't do that when the food industry is predatorily marketing products to children and engineering products for addiction, for instance. So you're working within the same shared value. You're acknowledging that you also have that value. And here's how this particular public health problem is sort of inconsistent with that value.
Yeah, I love both of those answers. So what I will add to that is, like, I think it definitely depends on the circumstance. So I don't think you're going to change anyone's mind in a social media where, conversation thread. That's going to be a lost cause. So that's probably not the best place to have like a rich conversation. Now, if you're in person, that might be a little bit different. And I agree with what Tracy and Jeff had said in terms of, again, like finding what you have in common. And I see there's a comment in there that not everyone values personal responsibility. But I think if we think about personal responsibility in different ways, we probably have some ways that we connect with that. We think about personal responsibility like in an academic sense, which kind of suggests that like everyone's on their own, and if you don't, do something, then it's your fault and up to you, and consequences be damned. That's like, I guess, one version of personal responsibility. But another version of personal responsibility is, yeah, I do want to take care of my health, and I want to know what I can be responsible in terms of health behavior changes, and how can I, what could help me do those things. So I feel like, with loaded terms like that, like trying to figure out like, What are the pieces of this that we probably do connect on? And then can we sort of build on that a little bit? And it's okay if we have differences, because we're going to, but where are the points of connection where we could get that in? Another great question to ask people is, why is this important to you? And if you want to kind of get at what their values are and why they care so much about it, where they feel so strongly about it. And that'll lead to kind of some interesting answers. And that conversation might be more effective than, don't you know that you should get a vaccine? Don't you know that this is going to do this? Because the minute we start lecturing or spitting facts, I think people shut down. So we want to be careful about that. It's that unsolicited problem solving that we have that knee-jerk reaction to doing, especially if like we're problem solvers, like for a career, right? That's all we do is we like problem solve. But we have to kind of hold back on that and try to connect instead.
Fantastic. I will ask one more question before we turn it over to the audience questions, and we have several really fantastic ones that come through. So my question is, if you could change one thing about how we train or support communicators in academia, in public health, in medicine and science, what would that be? And I'm going to turn that over to Dr. Pagoto first, since I know she's done a lot in psychom training.
I think it needs to be a part of graduate training. It's always been this kind of like side thing that interested people can attend. Go to the training on science communication, but it is not a part of curriculum, graduate or undergraduate, at least not in the spaces that I've been in. And so how can we better integrate that? Like the health communication, the communication people actually do a really great job of that. But outside of that, it's not an integrated part of training. And so we're training all these people to do great science, but we're not training them how to communicate that science, in which case that's why a lot of science basically dies in journals, right? Like it's published, we get happy because we got our publication, and then it sort of doesn't go anywhere because we're not sort of taking the lead in communicating what the important aspect of that science is to the public. And I think that's kind of why we got into this situation where we're not trusted. We're sort of over here in the ivory tower, pumping out papers, taking federal dollars to do grants, which is taxpayer money, and we've got very little to say about it. And so in some ways, I feel like we're responsible for this part, the part of the situation that we've got ourselves into. And so we need to be responsible for getting ourselves out of it. And that might be figuring out, what did we do wrong before? How do we train folks to learn how to communicate effectively?
That's fantastic. And you're spot on in terms of we haven't really taken our science to the finish line if we don't know how to maximize our impact. And that involves speaking to audiences that aren't on editorial boards and aren't in academic halls, but in places where people make decisions. All right, Professor Niederdeppy, what do you think people should be trained on?
Yeah, I generally agree with that perspective, although I don't think the responsibility should be exclusively in the hands of the investigator, because A, not all great scientists are great communicators, I guess I'll say. And B, I think this idea that all of the incentive structures surrounding science are based upon contributing scholarly knowledge, and they're not currently focused on translation or sharing of that knowledge, means that to say, oh, do this other thing in addition to all of the other stuff that is part of your job, I think is a lot to put on the backs of individuals. So I think what we need to do is provide institutional supports for amplifying and communicating and translational work. I think we need to invest in sort of infomediaries who are experts who can translate and synthesize accumulated findings across scientific research, not just like communicating about every individual study, which many of which, including my own, are incremental, but not, the final word on a topic. And so I think it comes to institutional investment. And I think we need to create incentive structures for scientists to do this and be rewarded for it. Because if you have those, they're going to be more likely to do it and do it effectively.
All right.
I generally agree with both what Sherry and Jeff said. I think, though, that One of the things that institutions can do to incentivize this is to have trainees work in communities, do their research in a community, and kind of what Sherry said, not to go in there and problem solve and spew data and be authoritative, but to go and work with communities and to listen, to hear the concern, to see health in practice or not in practice. And it could be local communities, it could be state communities, or it could be global communities across the world. But that's meeting where people are and translating that research not just into incremental science work or writing an op-ed, but interpersonally on the ground.
Yes, and I think this is a case where it's a yes and, not an either or. Yes, scientists, academics, we all have a responsible role to play. And this is really a team science approach. There are some really fabulous communicators that we can partner with who can do this work, who have trusted audiences. And so that also involves relationship building. All right, so we'll move on to some questions from our audience. One of our questions for our panelists is, how can we address information fatigue? And what are some ways to maximize engagement without overwhelming our audiences? This person is thinking about amplification of influencers. So let's see, Professor Hong, any thoughts on this from your perspective in the communication field?
I'm reminded by a very early research I did, which was school-based research in tobacco prevention. This was when I was a professor at Tulane. And I think schools are a great venue, particularly the K through 12, junior high, high school, where we really need to be designing interventions and curricula to teach kids that it's really not that great to be scrolling 5 hours a day, which is what I think the data I showed from the recent Gallup poll. But to teach that there is fatigue, that there is mental health issues associated with excessive social media use. So I think one way to do information fatigue is to design programs that are launched when kids are still learning how to use AI, social media in a beneficial way. That has to happen earlier on, and that's always more effective than later on in adolescence or in life.
Fantastic. Any other thoughts from Dr. Pagoto or Professor Niederdeppy?
Yeah, I mean, I think fatigue is a tricky concept for a couple of reasons. One, one of the things that is sort of tried and true in public health communication is that the single largest predictor of whether or not a public health campaign is likely to be successful is not to say that other things don't matter, but I think sort of most common reason why they fail is failure to achieve enough exposure, enough delivery of messages repeated over time in different contexts that are consistent with one another. And so I don't know that we reach a level of fatigue on public health topics individually all that often, because I think we're often out exposed by competing interests. I think the political, whatever side of the political coin you land on, I will say the political right is very good at repeating the same talking points in a consistent manner in lots of different places. And that is, I think, part of a resonant strategy. And I think public health is not as good at that consistency because we say, well, oh, it depends, and maybe because in this circumstance, and so that's not to say people aren't fatigued by a public health communicator saying you need to, do all of these healthy things all the time. And I think that stems from a sort of an orientation toward communicating as if health is the most important thing to everyone in their lives at all times. And people, as I think everyone on this panel has talked about, are value lots of different things. And health matters to people, but so does eating tasty food and spending time with friends and other kinds of things. So I guess the question is, what do we mean by fatigue? I think consistent messaging that reaches audiences repeatedly in lots of different contexts is actually generally beneficial for public health communication.
Fantastic.
Yeah, I think those are great thoughts. And I think it's a really tough question. And I agree with Jeff. Like, I don't know that our message are fatiguing anyone. But just the fire hose of nonsense is probably fatiguing people. So what I was thinking about, what would I say to this question? It was, what does not fatigue us? And maybe those are the strategies that we should be using. Like, we don't get fatigued by comedy. We don't get fatigued by things that are entertaining. Like, we could just do that all day long. So maybe we could learn a little something from our fine arts colleagues on like how to make things more engaging and entertaining. And so, yeah, just thinking about the types of things that people have a big appetite for, and why is that, and how can we inject some of that into our messaging?
Yes, those are fantastic ideas, the comedy and the entertainment for sure. All right, this next question, I will point to Dr. Pagoto first. What are some ways to debunk when there isn't necessarily a solution to fix the problem? For example, with a supplement or an unsafe practice. So I'm thinking, research that hasn't yet been conclusive on issues. Um, what should communicators or practitioners be doing at that point?
Yeah, so that is such a good question. I saw that in the chat and I was like, that's such a good question. Because we want to offer up something, right? And then we don't always have something. And like menopause is something I think about a lot right now based on my own personal experiences. And there's like a lot within that space where like, yeah, there are no good solutions. And so we feel very on our own. So I think what would be important in that scenario is to, instead of, so you may not be able to offer up anything else, but I think it would be important to say we have to be honest when we don't have a solution. And so I would be honest about that, and then also say the downside of trying that, because some people are like, I'll try the supplement. It's better than nothing. I'll give it a try. Is to kind of talk about the cost of doing that. We don't have data that works. Doesn't mean it doesn't, but it's going to cost you money. And you see that the bottle is making some false claims, and that makes me a little skeptical because they're saying things that they can't back with data. And by putting our money into something that doesn't work, like we may be, and putting our time into something that doesn't work, we may not be aware when things do come along the line, come down the line that do work. So we don't want to go too far down the rabbit hole of solutions that there is no data for. So I would just say, like, emphasize the cost of trying something that may not work. And another thing I want to add to that is we don't want to lose sight of shared decision making. This is something we talk about a lot in medical schools when we're training physicians, and physicians don't just say, you need to do this. They have a conversation. Here are the options. Here's what we know about those options. What do you think? So they're putting out all the pros and cons of the different options and then allowing the patient to have a say in that. And I think as public health professionals, we have to kind of have a similar approach of knowing that the patient or the public, or members of the public, like, they do get a say. We don't want to, dictate, but we want to give all the information that we have.
That's a great strategy. Professor Hong or Professor Nieder-Debbie, any additional thoughts?
I mean, I think Sherry's right. A lot of these debunking, pre-bunking, depending on what you read, very marginal effectiveness in correcting misinformation. And I've always seen these as sort of bandages, right? They're band-aid solutions. When a new misinformation, a new piece of information comes by, you have to do more pre-bunking or debunking. So how many bandages are you going to have on this problem? I think the solution really should be more systematic, platforms need to do more, right? They're doing community comments. It'd be interesting to see how effective these community comments are. But platforms need to do more, and we need to demand them to do more to clean the information ecosystem that we are immersed in. And that is just, I think, a more effective way to interact with information than just putting bandages after bandages on every inaccurate information that comes across our screen.
All right. Well, we have time for maybe one or two more questions. So another one that came up, and I'll point this over to Professor Nieder Deppie first, is let's say scientists or academics want to partner with other content creators or influencers. How do we pick the most effective ones who have large followings? What should the selection criteria be?
That's a great question. I mean, off the top of my head, I mean, I think one, and I alluded to this in my comments, I think rather than saying we need to use influencers to get our message out, the question I would ask is, who are we trying to reach? Number one, what media are they using, or which kinds of people are they following or engaging with? And that leads you to the question of which kinds of influencers do we want to engage with, right? So it doesn't start with a sort of a top-down approach. It starts with understanding your audience and learning how media ecosystems operate in their lives, and then identifying sources there. But then there's another layer, which is to say, is that person or set of people going to be a thoughtful partner, right? And is the message that we want to convey consistent with the broader set of messaging? So if they're selling, bleach, I saw someone bleach to kill HIV or something in the chat, is that a sort of person or platform that we want to invest in building a partnership with? Because they may be willing to transmit the message we say, but they're also saying a bunch of other things that we may not, that might not be consistent with a broader trust building approach for public health. So those are a couple of things that come to my mind. I'm curious to hear what others think.
Yeah, I'll say when it comes to influencers, I really think that we have to approach it like we approach CBPR, community-based participatory research, because influencers, content creators, put a lot of time into their brand. They build large audiences, and they don't want to be used. Just like we don't want to go in a community and use people to, do this for us, communicate this for us, let us do our research. So I think we need to partner with them and have discussions about like what do they see as their pain points, or what do they see as possible issues that they could elevate, and how could we work together, rather than just approaching ones you're like, oh, they have a big audience, that's the kind of audience that I would like to be in front of. Hey, can you post this? Can you engage in this types of messaging and that sort of thing. I think that's going to be a non-starter, just like it's a non-starter in the community. So this is just the online community, so it's no different than community leaders, online versus offline. So it would be great to see kind of like an online CBPR model where we bring in influencers and have these types of discussions. I think there was some of that going on a few years ago, I think maybe with Harvard. They're bringing in some influencers. I'd love to see more of that, of how can we connect and then come up with an agenda together.
I like both of those points. One, in terms of not thinking necessarily the first step, who's the influencer, but rather who's the audience I want to reach. And second, really approaching it from a partner perspective. And it's really about building that relationship and building the trust. So a few people have asked this question, and it's a complex one to unpack. So this is for everyone. Given that there are also a lot of negative effects of using AI, say, for example, the impact on environmental resources, potential health inequities it could exacerbate due to built-in bias. How do we navigate that when there are recommendations to use or to integrate AI in public health?
That's a good question. I kind of think about it in the similar ways, like we used to think about social media when it first started. There was a lot of folks who were like, oh, I don't want to get into that because it's so toxic and there's so many bad things there. So there's all these downsides. But these are the tools that are being used to facilitate health misinformation. So they're being used against us. So if we don't learn how to use them as part of our strategy, I feel like we'll continue to fall behind. That being said, I do think equity has to be part of our operating principle and how we use it. It has to be front and center. The issues around the resources that it uses, I think it's definitely a bigger question of using AI in general. And yeah, I don't have a good answer for that, but I think it's an important thing as a society that we need to be thinking about of what that's going to look like, because people are using AI for everything from homework, therapy to you name it, like all the things. And so that's a bigger question for all of us on how we're going to do that. But I don't think it means that we should abstain because it's already like the train has left the station when it comes to AI.
I agree with Sherry, and Sherry made a really good comment, which is when social media came about, a lot of people were very skeptical, and a lot of academic writing about, I think the potential negative effects of social media, and certainly there are, no doubt about that. But social media also gave us Arab Spring, which allowed pro-democracy uprising throughout Middle East and North Africa. So there's good and bad. The train has left. Hopefully the technology will advance where, these water using, electricity using GPUs will become more efficient, hopefully over time. Certainly a lot of investment from the government, from industry in wanting to facilitate AI and make it more efficient as well. So I don't really have an easy solution to say, except that we have to kind of look at the brighter side of this and how do we use it in a positive way.
Yeah, I'll echo those comments, as an educator, students are absolutely using it. And in my experience, telling them they can't is simply going to produce conflict and, attempts to subvert said prohibitions. And so I think that means, one of the things we need to do is surveil, much like we surveil diseases and we surveil the information environment. We need to know what kinds of systematic biases are being offered in AI platforms, and not just surveil, but sort of call it out, because that's not good publicity for ChatGPT if they're saying horrific things or spreading misinformation. That's not good for their brand or for their attempt to make money. And so that's, I think, one kind of surveillance role. I do think there are potential efficiencies in things like rapidly developing a survey or a set of messages to test on human populations. It's hard work to produce those kinds of messages. And it's also time consuming to recruit a sample of 4,000 respondents to test messages and then prior to use. I'm not saying you replace that with technology. I'm absolutely not arguing that. But as a tool to accelerate the process of sort of refining messages and developing, surveys and other kinds of research tools to then be more efficient. I think we have to weigh those benefits with the trade-offs that are environmental and otherwise. So, yeah, it's here to stay, though. I think there's no doubt about that.
Yes, it's a really complex and rapidly emerging field that it is really important for scientists and public health to have a place at the table and a voice in shaping that. So I believe we have time for about one more question. And I think in health and medicine, we tend to lean towards the negative. What's the disease? What's the negative health outcome? And there's not as much attention on positive or the resilience. And so I want to ask each of the panelists, what are some creative or evidence-based examples of successful health campaigns or successful misinformation countering that you've seen on emerging platforms? And how can we look to some case examples for some inspiration and some hope? So let me first point that to Professor Hong, since you're in communications, and love to hear what you're seeing and experiencing, and it doesn't necessarily have to be health specific.
Well, I teach undergrads, and the class that I see the most is the persuasion theory class. One of the things they do is that they have to take a persuasion principle and create a meme with it. So memes don't just have to be funny, but they can also convey a persuasion principle. And they do this very fast. So, partly it's because of AI tools that are available. I think that the most positive things I've seen here at BU, we had a campaign, a student-run campaign. You might remember this, Monica, during COVID, where we were trying to get people to adopt best practices to contain the spread of COVID on campus. And it was a campaign that was run through students at BU College Communication, completely run with the blessing of the administration, and it was widely disseminated. It was very successful. So I think a lot of organic campaigns that are from adolescents, from our college students, from our kids, they're really the future. They really know what is going to be next. And I think listening to them and having them do some of these launches can be particularly successful. And the one I come up to is the one that we had at BU and it was kind of controversial. If you remember, Monica, it was used a pejorative word, a campaign about COVID, but it was really successful. It was completely their idea.
I do remember that. And I think part of understanding why a message will resonate is understanding the culture of the audience. And so that may work really well for Boston or New England, and then understanding that you can't necessarily extract that and expect it to work in, say, rural Texas or suburban California. And so again, back to the issue about really understanding audience. All right, Professor Anita Deppie, any successful examples that give you hope or motivation?
Well, yeah, I mean, I think we've done far more studying of fear, sadness, other negative emotions than we have positive emotions. But I think there's a lot of potential for hope, as you have brought it up, as a sort of messaging, emotion, joy. A lot of people working in the climate space have been looking at awe as sort of a way of sort of thinking about a reason to take action for the climate. There's a little bit of work coming out of UCSB. Robin Nabby is working in this space on short. I think they're sort of inspirational, like media interventions where they invite students to watch a 5-minute kind of joy and like inspirational video, and they have tracked mental health outcomes related to that. And it's very preliminary, but I think some evidence of kind of reduced symptomaticity related to anxiety and some other kinds of things based on even just a kind of short media intervention. Now, of course, like it's more scrolling. It's 5 hours and 5 minutes than to Tracy's, data she presented on time being spent. But if we can convert some of that scrolling to some of these more positive emotions, I think there's good reason to think that could be better for us than doom scrolling, for instance. So maybe I'll stop there.
I like that. I like hope scrolling. And that's sort of, I hope that becomes like the word of 2026, maybe. I don't know. I'm like racking my brains to think of an example. And I see kind of smaller influencers on TikTok who do a good job of this. I wish I could like think of names offhand, who are really kind of positive and funny and do fun things. Since I can't think of like a great example to share, I'll tell you like a little something that we're trying to do in our lab, and we did some work on this, and it was actually really successful, where we're bringing in young people who engage in the very behaviors we want to counter message, and we incentivize them to create the content. So we didn't lecture them, you shouldn't be doing that, like it's cancer prevention. So we weren't lecturing them about their behavior. We were just saying, hey, we need you to be part of a campaign, and here's kind of like the messages that we want to get across. Make it your own. And we gave them small incentives to do this. And I'll tell you, the content they created, they were making TikToks, Instagram, like you name it. They were making such good content. I was embarrassed in terms of like how bad I felt like our content was compared to their content, and their content got way more engagement than our content did. And so I'm really into this idea now of bringing in people who are our target audience and having them create the messaging for people like them. And what we found, which is really interesting, and I've got a grant under review to do a bigger version of this, is that it actually changed their behavior. So through cognitive dissonance, like if you get people to speak about something, it does shift their attitudes and their behavior. And so we don't even have to lecture them. So I'm interested kind of in more of that. And I see this like kind of what's going on organically a little on TikTok, but if we could do that a little bit more of like bringing in our target audience and having them do the messaging, I'm just very curious of like how that could go.
Fantastic. These are all wonderful resources, and I know that many of our panelists have also shared resources through the chat on links, whether it's newsletters, different kinds of reports. In our last remaining minutes, since we're almost out of time, I will turn it back over to Dean Hyder.
Well, first of all, thank you so much. This is an amazing conversation. I want to thank Monica, you for moderating it so well. And thanks to Sherry and Jeff and Tracy and all of the fantastic engagement that I saw on chat as well. And hundreds of people were interested and they joined. So this is a remarkable and really important conversation. In fact, this is our final public health conversation for this semester. So you guys have done an incredible job at closing us for the series. I'm really excited also to announce that this series will continue as part of our 50th year celebration. So the Boston University School of Public Health will be celebrating its 50th anniversary in 2026. I invite you all to stay tuned. We're going to be announcing a series of very exciting public health conversations for next year. They will be posted on our public health conversation website, and we'll be doing a lot of collaborative work. And so excited to welcome you then. But for now, thank you, Monica, Tracy, Jeff, Sherry, and each and every single one of you who has participated. I hope you've taken something that you can adopt in your own work, in your own circle, in your own life, in your own professional, from the amazing conversations and the resources that have been submitted today.